Hi, this is Dr. Vallesh. Welcome to Pharmacology Simplified. In this video, I'm going to speak about pharmacology of adrenaline. This is a very important topic and it will be asked in your theory exam, practical exam, viva, as well as in your entrance exams. Now, before we move on, there are certain headings under which you need to describe any drug in pharmacology. These are introduction and classification, mechanism of action, pharmacological actions, pharmacokinetic highlights, indications or uses, ADRs, contraindications, precautions, interactions, and at the end, any other special points that you can remember that is significant about the drug. So let us describe adrenaline under the same headings. So let us start with introduction. So adrenaline is an endogenous catecholamine hormone. It is essential for life. It is secreted from the adrenal medulla. It is synthesized and secreted from only one place in the body, and that is adrenal medulla. Coming to classification, adrenaline is an adrenergic receptor agonist. It is a catecholamine and it is an endogenous catecholamine. This is the classification of adrenaline. So let us jump to the next heading, that is a mechanism of action. So adrenaline is an adrenergic receptor agonist and it activates all 5 types of adrenergic receptors. So there are 5 types of adrenergic receptors: alpha 1, alpha 2, beta 1, beta 2 and beta 3. Adrenaline activates, it's an agonist, activates all the 5 adrenergic receptor subtypes. Okay, slightly diverging from here. So adrenaline activates all the 5 types of adrenergic receptors. What about these drugs? As a tip, remember these 5 drugs in the same order: adrenaline, noradrenaline, isoprenaline, dopamine and dobutamine. There is a reason for that. Adrenaline activates all 5 adrenergic receptors. Noradrenaline activates 4 adrenergic receptors: alpha 1, alpha 2, beta 1, beta 3. It doesn't have beta 2 activity. Isoprenaline activates 3 adrenergic receptors: beta 1, beta 2, beta 3. It's a pure beta agonist. It does not have alpha activity. Dopamine activates 2 adrenergic receptors, alpha 1 and beta 1. It also activates dopaminergic receptors because it is dopamine, right? It has to activate dopaminergic receptors. So apart from that, it activates only 2 adrenergic receptors. So going by the sequence, dobutamine should activate only one adrenergic receptor, and that is beta 1. It is a pure beta 1 receptor agonist. It does not have any other action. It does not even have action on dopaminergic receptors. Dobutamine is a congener of dopamine. Despite that, dobutamine does not have any action on dopaminergic receptors. So remember the sequence: adrenaline 5, noradrenaline 4, isoprenaline 3, dopamine 2, dobutamine 1. This is on adrenergic receptors. Okay. So all the adrenergic receptors are GPCRs, G protein coupled receptors. So what adrenaline does is that it will activate, it will sit on the extracellular portion. There will be conformational change in the receptor leading to intracellular activation. This will lead to the effect. That effect depends on the type and location of the adrenergic receptor. Now, in high doses, alpha action predominates, and in low doses of adrenaline, beta action predominates. Remember this. Let me come back to this in a few minutes. Okay. Now, moving on. This is the mechanism of action. Moving on. Next heading is actions. So, pharmacological actions of adrenaline. It can be described under various systems headings. So, let us start with CVS. So, what are all the cardiovascular actions of adrenaline? So, cardiovascular system actions of adrenaline can be further described under 3 headings: cardiac, vascular and blood pressure. So what are all the cardiac actions of adrenaline? What are all the actions of adrenaline in the heart? In the heart, only beta 1 type of adrenergic receptors are located. No other adrenergic type of receptor is located in the heart. So adrenaline activates beta 1 receptor in the heart. This will lead to increase in heart rate leading to tachycardia, increase in force of contraction. There is also increase in the conduction velocity. So it will increase all the actions in the heart. There is increase in heart rate, force of contraction. There is also increase in cardiac output. All these are beneficial actions. There is one not so beneficial, undesirable action, that is arrhythmogenicity. It will activate the latent pacemakers, pacemakers which are sleeping as such in the AVN and Purkinje fibers. As a result, it is arrhythmogenic. It will precipitate or worsen or unmask arrhythmias. So all these are the actions in the heart. Next, actions on blood vessels. On blood vessels, different type of receptors are located. Alpha 1 receptors are there, beta 2 receptors are there. Which receptors is present on the blood vessel depends on the location of the blood vessel. So this is slightly complicated. Try to follow me here. So we need to understand what is the basic purpose of adrenergic system in the body. The adrenergic system is there to help us prepare for the fight or flight type of response. Correct? So whenever we are fighting somebody or whenever we are running away from something, we need some changes in the body, and all these changes are brought about by adrenaline. Okay, so for running away or for fighting we need energy. The body cannot synthesize so much energy in such a short span of time. So what it does, it will divert the blood and the energy contained within from the relatively unnecessary parts in the body to the essential parts of the body as far as the fight or flight situation is concerned. So in the fight or flight situation, which parts of the body are extremely essential? First one is skeletal muscle. Correct? So skeletal muscles are the one which are either running or fighting. Secondly, the heart, because heart is the one which is pumping the blood to all the locations in the body. So heart is essential in a fight or flight situation. Third is liver. Why liver is essential? Because in the liver there is rapid glycogenolysis, gluconeogenesis. The body is on a frenzy producing glucose. So these three are essential locations. So what the body tries to do, it tries to divert blood from all the places to these three locations. So as far as a fight or flight situation is concerned, which are all the less essential organs? Skin, correct? We need not look very pretty or beautiful in a fight or flight situation. GIT, renal kidneys. So all these are less essential as far as a fight or flight situation is concerned. So what adrenaline does is that it will take blood from all these unnecessary or relatively unnecessary places and it will divert it to the necessary places. How it does that? It does that by vasoconstricting in these locations and vasodilating in these locations. Okay, so adrenaline causes both vasoconstriction and vasodilatation. So what are all the places where vasoconstriction is happening? The skin. That is the reason why there is paling of the skin during adrenergic activation. Mucosa, viscera, renal blood, all these places vasoconstriction is happening, so that blood is getting diverted from these places to the more essential places in a fight or flight situation, which are skeletal muscle, coronaries, and liver. Now, how adrenaline does all these things? How one adrenaline does both of these opposite actions? That is by having acting on different type of receptors. So all vasoconstriction due to adrenaline is mediated by alpha 1 receptors. All vasodilatation by adrenaline is mediated by beta 2 receptors. Now there is an easy way for remembering this. Just remember your ABCDs. Okay, so A for alpha, put alpha 1 there. B for beta, put beta 2 there. So A will produce C, that is vasoconstriction. B will produce D, that is vasodilatation. It's an easy trick to remember. Okay. Now all these effects, vasoconstriction, vasodilatation, all these effects are happening in arterioles and precapillary sphincters. Adrenaline does not have that much effect on larger arteries and veins at normal physiological roles. Only in higher doses it will affect the arteries and veins. So I hope this part is very clear to you, what adrenaline does on different blood vessels in the body. Now as a side note, adrenaline does all these things. What about noradrenaline? What about isoprenaline? Noradrenaline, does it have any beta 2 action? No. So it will produce only alpha 1 effect, so there is only vasoconstriction. What about isoprenaline? Does it have any alpha action? No, it has only beta action, so it will produce only vasodilatation. Okay, so we have described action on the heart, we have described action on the blood vessels. And the third cardiovascular action is the action on blood pressure. The blood pressure action is determined by both cardiac action as well as vascular action. So there are two major types of blood, BP, systolic and diastolic. What happens to systolic blood pressure? The systolic blood pressure is determined by the cardiac action. Adrenaline increases the force of contraction, cardiac output, and because of this, systolic blood pressure increases. What about diastolic blood pressure? Adrenaline causes both vasoconstriction and vasodilatation, right? Depending on the location of the blood vessel, it will produce both vasoconstriction and vasodilatation. And as a result, diastolic blood pressure, there is no significant change. The vascular effect, because it produces both vasoconstriction and vasodilatation. So diastolic blood pressure, there is no significant change. Now, there are two derivative blood pressures, mean blood pressure and pulse pressure. What is mean blood pressure? Mean blood pressure is 1/3 of systolic plus 2/3 of diastolic. So what should happen? 1/3 of systolic plus 2/3 of diastolic. With adrenaline administration, mean BP should increase. Pulse pressure is systolic blood pressure minus diastolic blood pressure. So what should happen with adrenaline? Systolic is increasing, right? So pulse pressure also is going to increase. So if you can see, there is an overall pressor response. Mean BP is increasing, pulse pressure is increasing, systolic BP is increasing. As such, diastolic blood pressure, there is no significant change. So there is overall predominantly a pressor response. So you administer adrenaline, you expect the blood pressure to slightly increase or to increase. Now, in experimental setups, when you administer adrenaline, high doses of adrenaline, a characteristic biphasic response is seen. Initially, there is a rise in blood pressure followed by a fall in blood pressure before it returns to normal or slightly increased. So this is called as characteristic biphasic response. Why there is an initial increase followed by decrease and not the other way around? Because if you remember from one of the previous slides, adrenaline in high doses prefers acting on alpha 1 receptors and in low doses prefers acting on beta 2 receptors. So that is the reason for this characteristic biphasic response. Now, as a side note again, adrenaline does all these things. What about noradrenaline? What about isoprenaline? Noradrenaline, no beta 2 activity. So there is only rise in blood pressure. Vasoconstriction leading to rise in blood pressure. What about isoprenaline? It does not have alpha activity, only beta 2 activity. So there is only vasodilatation leading to fall in blood pressure. Now, we have seen this biphasic response. Let us slightly dissect this further. So this is the classical biphasic response. You give adrenaline, there is rise in blood pressure followed by fall in blood pressure. But overall, there is a pressor response. What will happen if you administer adrenaline after you give an alpha blocker? You give an alpha blocker and then if you administer adrenaline, what is going to happen? It is pretty obvious from here, right? You give an alpha blocker and then you give adrenaline. This response is abolished. There is only depressor response, right? So you administer adrenaline alone, there is a pressor response. You expect a pressor response. But you administer adrenaline after you give an alpha blocker, what is going to happen? There is a fall in blood pressure, the depressor response. There is outright reversal of what is happening in the blood pressure. So this reversal, this vasomotor reversal is called as Dale's vasomotor reversal phenomenon. This is a very important topic. This is asked many times in your Viva, in your theory exam, practical exam, everywhere. You need to remember this. Dale's vasomotor reversal phenomenon is extremely important. So let us summarize the cardiovascular effects. Cardiac, heart, it will increase the heart rate, force of contraction, and it is arrhythmogenic. Blood vessels, it causes both vasoconstriction and vasodilatation. All vasoconstriction is mediated by alpha 1, vasodilatation is mediated by beta 2. Blood pressure, there is an increase in systolic, no significant effect on diastolic, increase in mean arterial pressure, increase in pulse pressure, biphasic response, and vasomotor reversal of Dale. So all these are the cardiovascular actions of adrenaline.